Hello, everyone. Apologies for the delay. We had some technical issues that we needed to take care of. Thank you for your patience. Welcome, everyone, to today's webinar. I will be your host today. My name is Camelia, and I'm Work Package 6 manager. And today's topic is Klinefelter syndrome. Klaus is going to be our presenter today. Thank you to MTG7 for organizing this webinar. All questions usually come at the end. You can write them in the question box and they will be answered by Klaus for you. So without further ado, I will give the words to Klaus, and thank you everyone again for being patient.
Well, hello and welcome to this webinar on Klinefelter syndrome, from genomics to the clinic. So what do we know? Well, as you all know, most often we see the 47XXY karyotype, and we know that mosaicism is rather infrequent. We know that there is hypermethylation of the DNA in blood, muscle, and fat. Previous studies have shown that, compared with normal males and females. We also know that there are known transcriptomic changes in blood, muscle, and fat. And then we know from the clinic that there is an autoimmune predilection, which is very high. And we see a frequent occurrence of the metabolic syndrome and type 2 diabetes, and also frequent occurrence of deep venous thrombosis. And a lot of genes are now considered candidate genes, and those are the genes that are not inactivated on the normal X in, for example, females, and those genes are situated in the PAR1 gene in the PAR1 region of the X and the Y chromosomes. But there are also some XY homologous genes that are considered candidate genes, as you can see here. We have recently performed a new study, and here we looked at neurocognition and DNA methylation and gene expression data in two different cohorts analyzed separately. And then we also studied some neuronal precursor cells derived from Klinefelter syndrome and normal amniocytes. And in these analyses, a new gene that is actually not situated on the X or the Y chromosome, but on some other chromosome, the TRAC1 gene, emerged as a gene that was correlated with a lot of different neurocognitive traits in Klinefelter syndrome. And it turned out that the methylation of this gene was different from normal males. We could see that the methylation levels at 5 different CG sites in the TRAC1 gene were correlated with a high expression level of a specific short TRAC1 transcript when this TRAC1 gene was hypomethylated. And this correlated with a lot of different neurocognitive traits in Klinefelter syndrome, for example, IQ. And what does TRAC1 do? Well, it has an essential role in mitochondrial motility in axons, and it's an adaptive protein that links mitochondria to kinesin 1 and dynein. And TRAC1 variants have been linked to autism and other neuropsychological disorders. And in the cartoon here, you can see the TRAC1 short isoform, which was highly present in Klinefelter syndrome, and this seems to lack the kinesin 1 binding region. And therefore, we speculate now that this leads to less mitochondrial transport in axons, and that this may be linked to the neurocognitive phenotype that we see. We've also just completed another study where we looked at the ECG and expression of the pseudo-autosomal gene SLC25A6, and here we could demonstrate an inverse relationship between dosage of this gene and the QTC interval in the ECG, knowing already that the ECG interval is shortened in Klinefelter syndrome. So this seems to add to the picture of the genomics of Klinefelter syndrome, which we now picture like this, where we see the extra X leading to a lot of different changes in the epigenetics, in the RNA expression, and the protein expression. And today, we think that that we can see Klinefelter and Turner syndrome as kind of mirror images, at least when we're looking at the genomics, and we think that we can link different genes and different genetic mechanisms to, for instance, neurocognitive traits, as I just showed you. We have shown recently that the TBL1X gene is especially linked to inflammatory distress in Turner syndrome. We already knew that the SHOX genes was associated with increased height, and now I just told you that the SLC25A6 was linked to the QTC interval. We've also shown that the ENPP4 is associated with impaired fibrinolysis in Klinefelter syndrome. So the perspectives of this is that I think we can state that the genomics of Klinefelter syndrome is now being unraveled, and that we probably have to think of every trait in Klinefelter syndrome as linked to one or more genes, one or more genomic mechanisms like changes in methylation and so on and so on. Having this knowledge will help us in the future to direct new treatments and new ways of thinking about Klinefelter syndrome. So after this genetic introduction, we can state that the genomics of Turner syndrome and Klinefelter syndrome is becoming untangled. Subtle changes are present at many sites in the genome with discrete hypo or hyper DNA methylation affecting gene expression. Subtle changes in RNA expression is also present, likely leading to unbalanced expression of many different genes. And changes are also, which I haven't showed you here, but they're tissue specific, and thus we probably need to examine all relevant tissues. Changes may also be temporal, meaning that in fetal life they may look in one way, and later on in life they may look differently. And it seems that if every trait in Klinefelter syndrome may have its own explanation. And it's also important to state that we don't understand everything yet. And of course, you know a lot about Klinefelter syndrome. We know that there are changes in body composition, cognition, as we just discussed, the cardiovasculature, fertility, immune system, and metabolism. We know that there is a decreased muscle mass and strength. Abdominal obesity is frequent, especially when kids grow up and become adult. I usually say that between the ages of from 20 to 30, most Klinefelters gain considerable weight. We see higher plasma fasting glucose and insulin resistant. Type 2 diabetes is very frequent, as is the metabolic syndrome, and increased triglycerides and decreased HDL cholesterol. And there are a lot of traits and diseases, conditions in Klinefelter syndrome. I've listed some of them here, and many of these may be responsive to testosterone treatment. I will return to that later on. But for example, abdominal adiposity and increased body fat responds to testosterone treatment, and also osteoporosis and osteopenia responds well to testosterone treatment. And of course, all the typical features you link with having no testosterone also responds well, as gynecomastia and decreased beer growth and so on. However, it's also perhaps surprising that the occurrence of venous thrombosis, which is very much increased in adult Klinefelter syndrome, responds also to treatment with testosterone. And one of the things that we know now is that mortality is increased in Klinefelter syndrome. We see a median loss of 5.6 years, and we see that especially during the young ages, there is an increased mortality. However, this is important to state, we are not diagnosing all with Klinefelter syndrome. We only diagnose about 25 to 40% of the expected number of Klinefelters, and only 10% are diagnosed during childhood, adolescent years. The median age of diagnosis in Denmark, at least, is 27 years, and the majority of patients are diagnosed because they come to a fertility clinic where they are diagnosed. So the age of diagnosis has a very a large spread, as you can see here, but the median age is 27 years. But as I said before, it's very important to state that a lot of Klinefelters are not yet diagnosed. And how this population look, we did not know a lot about until these large studies like the UK Biobank study showed data that suggests that the undiagnosed Klinefelters are actually just as metabolically sick and in other ways affected as the diagnosed Klinefelters. So what leads to diagnosis? Well, this is really this is dependent on the age of the individual. So in the newborn and the infancy and childhood years, we have one set of symptoms that lead to diagnosis. During adolescence, it's lack of puberty, small testes, and so on. And during adulthood, we see other causes that lead to the diagnosis of Klinefelter syndrome. Can we look at a male and then determine that he has Klinefelter syndrome? I would say no, although the bitesticular volume is of course very low in most Klinefelters. However, this is also present in other conditions. And if you look at the anthropometry of Klinefelter syndrome, you can see that not even height, which we know is increased, is not that increased, and it actually is close to a SEED score of SDS score of 0. So how many do have Klinefelter syndrome? Well, we know from previous studies that about 150 per 100,000 males will have Klinefelter syndrome. And that's about 4,200 in my country and 345,000 in the EU. However, we don't have epidemiological studies from almost all the rest of the world. The only 3 countries that have contributed with epidemiological studies is Sweden, Denmark, and the UK. So the way we diagnose Klinefelter syndrome does not work if we want to diagnose males early on in life. Many are late diagnosed, some are never diagnosed, and we have been discussing whether we should screen the entire population, or at least a part of the population. Could the surveillance by GPs and school nurses be improved? We don't think so. This has been tried in some countries and doesn't seem to work. Should we use the heel prick test on newborns to diagnose Klinefelter syndrome males? This is a question that we need to ask ourselves and see if we can answer. So, of course, we all know that you can get the extra X either from the mother or from the father by maternal or paternal non-disjunction. We know a lot about the phenotype, and we know also about the neurocognitive phenotype and different aspects of the syndrome, as I have gone through earlier. If we look at the neurocognitive side of Klinefelter syndrome, we know that a lot of conditions are seen more frequently, but as you can see here, the numbers that are presented in different publications vary a great deal. This is autism spectrum disorder, this is ADHD, anxiety, depression, psychosis, and so we can see that these numbers differ very much from different studies. However, what we know from clinical studies is that language is affected. We see delayed speech development, verbal deficits, dyslexia, and this is something that emerge early in childhood and persists into adolescence and adulthood. And this affects both the receptive and the expressive language. As much as 70 to 80% have verbal deficits, and about half or a little bit more will have dyslexia. So how about executive function? Well, there are studies that show less inhibition, a poorer working memory and attention, and less cognitive flexibility in Klinefelter syndrome. This can lead to a lot of problems during everyday life. And when we look at the MRI imaging studies that have been performed, they have more or less found similar findings, with reductions in a number of different brain nuclei, and also in total gray matter and total white matter volume, while the total ventricle volume is increased. And these different brain nuclei are related to a lot of different important functions. And we think that this may lead to the personality profile, which has been described as reserved, passive, unassertive, less talkative, less energetic, and so on. And this may also be linked to the increased risk of psychiatric comorbidity. And so how about the IQ? Well, there are a number of studies which are presented here and that have presented full-scale IQ. And as you can see, most find that full-scale IQ is reduced by about 10 points in comparison with a background population. And this is both verbal IQ, which seems to be more affected than performance IQ. So how about school? Well, the percentage of Klinefelter boys receiving special help in primary school is above 50 in all studies that have presented data. And when you ask about quality of life in adults with Klinefelter syndrome, you normally see a reduction in a lot of different aspects of quality of life. Here we have presented data from the SF36 and from the WHO quality of life questionnaires. And as you can see, for almost all measures, Klinefelters report lower quality of life. We also know that the psychological strain during different phases of life is quite affected. Here we asked all the way through school, primary school, teenager, and moving away from parents and so on. And almost across the board, we saw that Klinefelters had more distress during these perhaps difficult times of their life compared with a control population. So now turning to mortality, morbidity, and testosterone replacement therapy. I said already that mortality was increased in Klinefelter syndrome, and this is a study from the UK where they looked at what actually kills people with Klinefelter syndrome. And here you can see that diabetes, mental disorders, epilepsy, and vascular insufficiency of the intestine and other conditions are causing the increased mortality. And this is, of course, something we think that we could and should reduce, but how to go about that. If we look at bone metabolism, osteoporosis is more frequent, as I've already said, and likely the result of hypogonadism. And we have estimates that say that about 5 to 10% of Klinefelters will develop osteoporosis. We have also found low volumetric bone mineral density and reduced trabecular density at the tibia in a similar fashion as what we see in postmenopausal women. However, we have no data regarding the effect of testosterone on bone microarchitecturally changes. On the other side of this cartoon, you can see how the different cortical thickness and so on is affected by having Klinefelter syndrome. And in general, as I said, this mimic the picture seen in postmenopausal women. Turning to cardiovascular disease, this is kind of complex because, as I said, the risk of venous thromboembolism is clearly increased. This has been shown way back more than 40 years ago, and different studies have shown that the risk of venous thromboembolism is 5 to 8-fold increased. And we can also see that when Klinefelters become the age of 70, 1 in 5 will have a diagnosis with VTE. And this is much more than in the background population. So, and since we also know that treatment with testosterone can lead to VTE, we thought that we wanted to take a closer look on how testosterone treatment actually interacts with venous thromboembolism. In this study, we looked at the medication that males with Klinefelter syndrome receive and compared with a 100-fold as large a background population. And here you can see that Klinefelters receive a lot of medication that is linked to the heart, anticoagulation, platelet inhibitors, statins, antihypertensives, and so on. And you can see that for all these medicines, they are used more in a Klinefelter cohort. When we looked at the comorbidity, we could also see that atrial arrhythmia, hypertension, diabetes, hypercholesterolemia, angina pectoris, and arteriosclerosis was much more frequent in a Klinefelter syndrome cohort. We also know that males with Klinefelter syndrome have an increased truncal fat percentage. This is a clinical study we did some years ago. And here you can see that for a given BMI, here 25, a normal male will have a truncal fat percentage of about 18, 19, while a Klinefelter male will have almost 25 or something like that. So much more truncal fat, which should also lead to more cardiovascular diseases. This seems to be present already during youth. This is a study in teenagers, and here you can see, or pre-teenagers, and here you can see that even in pre-teenagers, there is an increased body fat content in Klinefelter syndrome, even in those that are androgen substituted. We've also looked at skeletal muscle mass, and here you can see that for a given amount of muscle mass, Klinefelters have a poorer physical exercise capacity. So even with the same amount of muscle, they simply do not have the same physical exercise capacity. We've also looked at muscle strength, and here we can see that muscle strength is lower and is correlated with the lower muscle mass and also the low testosterone. And in this study, we looked at abdominal fat mass and found that it was lower than in controls. And in those that were treated, we could see that they had a lower testosterone treated. We could see that they had a lower abdominal fat mass. So this led us to perform this study where we looked at the epidemiology among Klinefelter syndrome in Denmark. And here we matched the Klinefelter syndrome persons receiving testosterone with those that were not receiving testosterone. About half of all Klinefelters in Denmark, we can see in the registries, are receiving appropriate testosterone treatment. However, the other half are, for reasons that we don't understand, not receiving appropriate testosterone. We've previously shown that the untreated part of the Klinefelter syndrome cohort in Denmark is really hypogonadal and should be offered testosterone treatment. And in this study, we could see a clear reduction in mortality among those that were treated with testosterone treatment. You can see that the all-cause mortality in the treated population was with a hazard ratio of 0.60, which corresponds to a reduction in mortality of about 40%. And you can see here that the untreated had a much higher mortality. So this is the first, at least indirect proof that testosterone does something very dramatic to the all-cause mortality in Klinefelter syndrome. We went on to see what kind of conditions were reduced when we looked at treatment, and we could see that cardiovascular deaths had a hazard ratio of 0.53. So this was almost halving of the mortality risk due to cardiovascular causes. Very reassuring when we think about treating with testosterone. And then in a previous study, we looked at what was the effect of testosterone treatment on the occurrence of venous thromboembolism. And here you can see that in this cohort of about 1,155 compared with about 100,000 in the control cohort, you can see that there was an elevated risk of about 4 of having VTE. This is illustrated here. Much higher risk of VTE among Klinefelter syndrome. And here we then compared the risk of having treated Klinefelter syndrome and untreated Klinefelter syndrome, and the risk of having TRT. And as you can see here, or having a VTE, and here you can see that there was actually a reduced risk among the treated. So it also seems that although this was not quite significant, that testosterone somehow protects against VTE. So what do we treat? What can we treat our patients with? Well, in Denmark and in many places in Europe, we have either injection therapy or we have the transdermal therapy with gels. And for now, we don't know whether one or the other treatment modality is to prefer. This is a study of the characteristics in our outpatient clinic, and here we studied all the patients that had been seen for at least the last 5 years in the clinic, and we looked at age at initiation of testosterone therapy and height and weight and so on. We compared the group that received injections with the group that received gel. And as you can see here, the serum testosterone level was similar in the two groups, although serum FSH and LH was much lower in the injection group than in the gel group. We think this has to do with the pharmacokinetics of the gel that quickly is absorbed and then also quickly removed from the circulation. However, when we looked at cholesterol profile and a lot of other profiles, we could not find any differences between the two groups. It is, of course, important to state that this is not a randomized control study. This is purely observational. This is just a picture of the testosterone level, which was more or less comparable and within normal limits. And here you can see that FSH and testosterone, or LH, was higher in the transdermal group compared with the injection group. However, when we looked at one of the measures that is affected by testosterone, hemoglobin, you can see here that it was totally comparable. We also, in this study, looked at how does our group with Klinefelter males do over a period of time. And here you can see that there is a steady increase in BMI, which is something that worries us quite a bit because many become quite obese with age. Some years ago, we did a RCT of testosterone use in Klinefelter syndrome. This was a very, very difficult study to perform because not many Klinefelters wanted to participate. They simply did not want to have the placebo treatment. However, we had 13 Klinefelters, as you can see here, and total abdominal fat by CT actually diminished during active treatment with testosterone compared with placebo for half a year. You can also see that hemoglobin rises, although not reaching the level of controls. And you can see that IGF-1 also increases in response to testosterone treatment. So the effects that you would anticipate are present in Klinefelter syndrome. I alluded to this before, and even though we now think that testosterone treatment is very effective, and that we also now think that it reduces mortality among patients with Klinefelter syndrome, only 48% of patients with Klinefelter syndrome in Denmark are actually treated with testosterone replacement therapy. And this is, for us, rather difficult to explain. We can say that all the patients that we see in our outpatient clinic, about 450, are basically treated. I think we have 3 patients that are not receiving treatment because they simply don't want testosterone. However, the remaining part of these patients, we have looked into their biochemistry, and we can see that this shows that they actually do, to a large extent, have hypogonadism. So why are they not being treated? We don't know, but we think that this may be due to lack of knowledge among the treating physicians, and we think that we must do something about this. Talking a little bit about the socioeconomic status of Klinefelter syndrome, we can see some data here. They're somewhat old now, but here you can see that Klinefelters retire earlier than the control population. You can also see here that the annual income is much less than what is seen in the background population. And we can also see here that more with Klinefelter syndrome live alone. So what do we know about testosterone treatment? Well, we know that it increases testosterone, hemoglobin, and IGF-1 in blood. We know that it reduces fat mass and the risk of developing gynecomastia, and it stops the development of gynecomastia if a patient already has this. It may increase muscle mass. I think we can say this for sure now. And it seems to reduce the risk of venous thromboembolism, and it may reduce the risk of depression. It likely improves well-being, and it may also decrease the risk of type 2 diabetes. I think we can say that it decreases mortality, and we therefore recommend appropriate testosterone treatment in Klinefelter syndrome. So what can we do additionally for patients with Klinefelter syndrome in addition to giving them appropriate testosterone treatment? Well, it is clear that many will have a need for scholastic interventions during both primary school and perhaps also later. Psychological treatment, especially with focus on the neurocognitive abilities, is something we use increasingly, and we offer this to all our patients currently. Information about the syndrome to patients, parents, family, and friends is very important and something that has been overlooked, I think. And fertility preservation is something else. Currently, we can treat patients with or giving them the option of having TC performed, and this seems to work well, but only in the ones where we can find viable sperm. And now we think that perhaps up to 40% will have viable sperm. However, only about a subgroup of these will eventually see a pregnancy. And then I think it is fair to say that we need to prevent a lot of the associated morbidity that is seen in Klinefelter syndrome, and this can be done in different ways, but we think that care should be anchored in the endocrine departments. And what we do in Denmark is that we transfer adolescent patients in the transition clinic from the pediatric department to the adult department. And then the adult endocrine clinic is the anchor department and looks out for relations to other relevant departments. And we then have a number of research projects with several of these departments. Who do we partner with? Well, of course, a Department of Fertility, also odontology. There are many that have severe problems with their teeth. Plastic surgery is needed for those with gynecomastia. Department of Neurology in patients with Parkinsonian-like symptoms. Cognitive neuropsychologists, And then we also work together with imaging departments of the brain, and we work together with Department of Linguistics and Cognitive Science, and then Department of Cardiology when necessary, and urology and orthopedics and others when needed. So what is the role of the adult endocrinologist? Well, as I said, he or she should be the anchor physician and establish collaborative agreements with other departments, as I said, spread knowledge. And what we do is that we have information days for patients and relatives at the department. And then, of course, we still need a lot of research. There are a lot of things we don't know about Klinefelter syndrome. How to monitor? Well, we really don't have any consensus. We monitor using LH, FSH, hematocrit or hemoglobin, testosterone, DEXA scan to monitor changes in body composition. PSA may be checked to monitor growth of the prostate, especially in older males, although we have yet to see a case of prostate cancer. And then talk about general well-being, increase in muscle strength, increase in quality of life, and so on. And these are the persons or the team that have helped me and others perform all the research we've done over the years, and these are our funders. So with that, I would like to thank you all for staying, if you did, and listening. I will be ready for some questions if you have some. So there's a question about mosaic and non-mosaic Klinefelters. Well, for now, we have only a small population of mosaic Klinefelters, and what we probably can see is that they have fewer symptoms than the non-mosaics, and we can also see that we have one that is a mosaic, and he was actually fertile. So so they probably have a milder phenotype. And then there is another question here about gender incongruence, and how common is that? That is something that is it's difficult to state. I think we looked in Denmark to see if any had changed sex, and we didn't find any in an epidemiological study. However, I have one patient that has changed sex and now is receiving estrogen therapy. If this is more frequent than in the background population, I don't really know, and I think we need to wait for better data. And then what are the chances of fertility in non-mosaic Klinefelter? Well, without intervention, it is basically zero. However, if you offer TC to the patient in the age range from, let's say, 20 to 40 years, we will find live sperm in about a little less than 40%. Of these, only a minority will end up with a baby. So this is not something that always leads to a baby, because many times they, for instance, the last patient we had, they found 9 live sperm, and none of them could be used for fertilizing an egg. So although there was spermatocytes, it was not enough. So okay, and then does the origin of the X chromosome, is that relevant for specific phenotypes? This has been examined by us and others, and I think the general thinking now is that the origin of the extra X chromosome is not something that influences if the phenotype. However, it is important to mention that we probably have too small a cohort. So for that, to answer that question, I think we need much larger cohorts. Okay, and then there is there a relevance for origin of the surplus X chromosome in terms of genomic methylation in Klinefelter patients? And this has not been examined up until now. We should, of course, have some data, but I don't think we have enough. So we would need probably several hundreds patients to answer that. Question. And then there's another question here. Does having the Klinefelter syndrome reduce the sperm count? And yes, very seriously. And of course, this is something that I mean, we don't understand why. I call it a testicular catastrophe happens when they enter puberty. However, we would very much like to understand what is going on there and what is happening. If we knew that, maybe we could do something about it. And then there is a question here: is your patient taking estrogen? Is she gaining the same benefits as those on testosterone? And well, I guess she should be viewed just as any other transgender individual, and on those there is a certain amount of literature stating that male to female have quite a substantial morbidity burden in comparison with a normal control population. So it is important to talk to these patients and to tell them that they need to stay healthy, not gain weight, and so on and so on. And yeah, the quality or the quantity of sperm. Well, as I said, the production of sperm is very limited. And the last patient we had for TC, he had 9 viable spermatocytes, and that was not enough to get his wife pregnant. So this is clearly a problem, and so it's safe to say that we need to develop better techniques if we want to help these patients. Does testosterone therapy pose risks that outweigh its benefit? No, not at all. The other way around. Testosterone therapy poses benefits that seriously outweigh the risks. For now, I don't think that we can think of risks that is connected to testosterone therapy if you take the amount that is suggested by the physician. It is clear that if you take too much, there will of course be risks like in doping and so on. But if you just substitute, as we call it, just normalize the testosterone level, we don't see any risks for now. We're looking into this right now. We're looking into further epidemiological studies, and they suggest that we don't see any risks. We see benefits instead. And then there is a question here: if Klinefelter syndrome isn't enough detected in population, how can we improve the detection? Well, we don't think that we will ever diagnose Klinefelters based on clinical phenotypic traits. And we think the only way of going about it is to use the heel prick test on newborns and then diagnose it with some kind of of genetic test, not a karyotype that is way too expensive, but other type of genetic testing. And then there is a question here: what percentage of patients eventually father children given the low sperm count, and does this decrease with age? Within the age range 20 to 40, we think that that about 40% will have sperm, and of these, perhaps 20 to 25% will achieve a pregnancy and give birth. So it is clearly a small minority that eventually fathers a child. Does direct intranuclear intrachromosomal interaction play a role in the pathogenesis of aneuploidies like Klinefelter syndrome? And this is a very interesting question, and it's actually a favorite of mine, and I think that it does. However, nobody has been close to showing or proving or disproving this, but it may well be that the extra X floating around in the nucleus somehow interact with other genes on other chromosomes, and then because of the 3D topology of the nucleus, interferes with normal action of different genes. We don't know simply. What age should we start testosterone therapy in children or adults? Well, the Danish way of doing it is that we start testosterone as soon as LH rises. So we do not wait for testosterone to fall, because that takes many years. So as soon as testosterone LH rises, we start treatment, and that means that most of our teenagers that are diagnosed will be treated with testosterone. And this is something that we have had discussions with our colleagues in other countries about. Many wait until testosterone falls, and then we think it's way too late, because many body compositional changes will have occurred. The coagulation picture will be wrong, and maybe some have even developed DVTs and so on. So we are very much proponents of early start of testosterone. We still need to prove that this is the right way to do, but I hope we will be able to do that soon. And this is this was the last question. So thank you for listening and for having some very, very interesting questions. Thanks very much.